Okay, we start in about 25 minutes. So you can do some homework.
Good afternoon, doctor. Good night. Yeah, thank you. I was joining because otherwise I would forget again.
Hello, is that you, Stephanie?
Yeah, doctor. Good night. How are you?
Hello, is that you, Stephanie?
Yeah, doctor. I'm here. Can you hear
Can you
me?
hear me?
Yeah, I can hear you. Can you hear me?
I can see. I can hear. Testing. Can you speak, Stephanie? Are you speaking now?
Yeah, doctor. I have my microphone on.
Looks like you are, but I can't hear you. Can you hear, Wayman Zhang, can you hear me? Well, let me see if the music is. I'm here if I
Night,
hear
doctor. Yeah, I
the
can hear you.
music. Oh, okay. I can hear it now.
Good night, doctor. Can you hear me now?
Oh, Stephanie,
Good
Hello,
night.
Stephanie.
How are you? I could hear you the
Just a
entire
minute. Is someone else talking?
time. When you were asking me, yes, I was answering, but
Hold
I
on,
thought,
hold on. Okay. Stephanie, ¿tú vas a
yes,
venir mañana? ¿O no, domingo? Mujeres de Neurosurgery.
sábado, ¿cómo? ¿A dónde?
Déjame mostrar. Ok, espera.
Sí. ¿Cómo aprendió a hablar español, doctor? ¿Se entró a cursos o cómo aprendió?
¿Tú conoces Griselda?
No.
Ok. Espera. Ok. Yo, yo voy a mirar mi página de Facebook. Todas las cosas están allá.
Ah, sí, sí, ya lo tengo agregado y sí,
Tú
me
es
salieron.
mi amigo, ¿verdad?
Sí, sí, le mandé solicitud.
Ok. Ok. Sí, tenemos un charla en español lunes de
Ah,
Perú.
sí, sí, claro que
De
sí,
Perú.
pero
Tú conoces a la gente,
presencial,
yo creo. El Hospital Cayetano Heredia.
no,
Oh, ok.
no, no.
Ok,
Eso, yo
esta
soy de
noche
Bolivia.
es esto.
Sí, tal vez Uriel conoce, Uriel, Manuel.
Sí, déjame mostrar la charla de mujeres.
Ah, sí, va a haber una charla de mujeres en neurocirugía con una doctora de México.
Sí, aquí,
Sí,
Griselda.
ah, sí, 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 la doctora, sí.
Sí, por favor, venga y
Sí, sí,
hace
voy a estar.
preguntas de ella.
Sí, está bien.
De
También voy a
domingo
invitar
a las 8,
varios
tiempo
compañeros.
México, es lo mismo
Ujú.
tiempo. Tú estás en Ecuador, ¿verdad? Ecuador, ¿verdad?
Bolivia.
Oh, Bolivia. Oh, ok. Es lo mismo tiempo como México.
Ahora, a ver, creo que no, creo que es una hora
Oh, ok,
adelante.
well, 8 en México.
Es una hora, por ejemplo, aquí son las 7, México son las 6. Así.
Oh, ok. Sí, estoy confundido a veces. Porque
No se preocupe, sí.
Chile es extraño. Una hora enfrente, no detrás.
Sí, sí, ajá, Chile igual. Pero,
Confundido.
por ejemplo, creo que tenemos la misma zona horaria en Miami. Creo que sí.
Yeah. Ok, yo
Sí, tenemos
regreso.
la misma.
Yo
Está bien.
regreso, ok.
Ujú.
Bienvenido todo. Empezamos en 6 minutos. Oh, so we start in 6 minutes. I keep thinking we're Spanish. Spanish show. No, it's Stephanie. You make me think it's Spanish. Stephanie, where is Francisco? It's no big deal, but I thought he was going to moderate.
Yeah, I will write in the group.
Do you can moderate if you want. Do you want to moderate?
I don't know. I just got in, so I will write to Francisco.
Well, you know what it is, right? All you do is any questions, and you introduce Iype first, okay? Iype Cherian, and just say a few words about him. Can you read about him real quick? You can say he's a well-known educator from India. That's all you need to say, okay?
Okay.
That's all. I'd like to introduce Iype Cherian, a well-known educator from India. And then he takes over.
So, doctor, he will be running like he will be presenting Dr. Mura, right?
He'll be running the show. I don't know what he's going to do. I don't know if he's going to the last time he let Dr. Present, and he would interject. He runs it, he decides. So you don't have to worry about that. And at the end, you just say, thank you very much. And I think he's going to be doing answering the questions or asking the questions. He'll run it essentially. Here's Iype.
Hi.
Hey, Iype,
Hey, John. All
how
good?
you doing?
Hey, John.
Iype, Stephanie is going to introduce you, okay?
Okay.
And then Jorge's not, oh, here's Jorge now. And you just run it, Iype, however, whatever you want to do.
Yeah. So you want me to tell you in short as to what are we going to do in this Ignite interview?
No, Stephanie's going to say, I'd like to introduce Cherian, and then you take it. And you run it the way you want to run it.
Right.
Okay. Let me get Dr. Muros in here. If people are starting to show up now, just wait a minute. Okay.
Is Jorge here?
Jorge, you here? Did you get in? I think he did. How you doing, Jorge?
Fine, thank you.
Hey, Jorge.
Okay, you ready to start, Jorge?
Yes, sir.
Okay, here we go. Stephanie, I'll go 5, 4, 3, 2, 1, and then you take it. Okay? Okay,
Okay.
Stephanie, you ready? 5, 4, 3, 2, 1.
Good night, everyone. Thank you for joining us. We are here in your neurosurgical.tv, your favorite neuro channel. We have here Dr. Iype Cherian, who is a very well-known doctor from educator from India, and he will be running the meeting. Welcome, doctor.
Hi, Stephanie. Thank you. Jorge, good morning. And rest of the world, good morning, good evening, everything to you. So we are into the second topic here. We had gone with me plata for the first time. Now we are on to the second topic, which is revascularization. We again have Jorge, my good friend. And we'll be talking about something that the young neurosurgeons have not been, I guess, paying attention to in many places right now. This could be due to the advent of interventionary procedures like coiling and embolization and stuff, but then, and plus one trial which probably put this out of practice, revascularization, which was commonplace before, but then it slowly went into obscurity. And then right now, there are very few doing it. There are people doing it, but very few doing it properly. So we are going to hear from Jorge about starting revascularization for young people. How do they start off with STMCs, which is by far the most commonest form of anastomosis? Then how do we graduate into from STMC to double barrel bypasses, then going into high flow bypasses, then different combinations, and then side-to-side anastomosis, end-to-side anastomosis, and end-to-end anastomosis, and then probably anastomosis in the depth. Well, most of it is not required in daily neurosurgical practice. You can get away without it. But then the point is, when you can have a perfect scenario, why compromise for something which is less perfect? So that would be my question. So I would ask Jorge to start with STMC indications primarily, and how an anastomosis can get you out of trouble. There are many misconceptions. People sometimes ask me, okay, I clipped the aneurysm and I probably clipped part of the ICA. And I don't have time I don't think there is enough time for a bypass right now. So why should I even do one? So there are misconceptions like this. And I would like Jorge to show mostly videos of maybe beginners bypasses, and then over to complex bypasses, the technique. Also, how do you prepare the patient? Say, for example, in my practice, I just give aspirin. I don't, I mean, during bypass, we give 5,000 units heparin, but otherwise, nothing except aspirin. Some people don't agree to that. And I would like to have his view also as to what is the dosage, what do you give, how much time can you wait till the bypass is on, what is the importance of it this in stroke surgery, what is the importance in bypass surgery, I mean, what is the importance in aneurysm surgery, and so on. Thank you, Jorge. Why don't you take over and show us some videos?
Okay. Thank you very much for your introduction. Let me share my screen. I got several lectures about cerebral revascularization. I picked one of those for today. I got a special one, a revascularization lecture about ischemia, only for ischemia. And everybody knows about the chronic ischemia of moya or whatever, but I for the future, maybe in another session, we can talk about acute or stroke revascularization. Stroke revascularization is very interesting. We will talk a little bit today. It's a thrombectomy, microsurgical thrombectomy that is very good. Results are as good as endovascular. That is the gold standard. And we have as well the bypass for stroke. Okay. And another lecture as well for just general revascularization. But today I want to show you my presentation for aneurysms. Why aneurysms? Because I think that we cannot talk together ischemia and aneurysms. And ischemia is more complex for the physiopathology. And then it's easier to talk about revascularization for aneurysm because it's very simple to talk for aneurysms. And we can go showing the different kind of bypasses, the different kind of suture, and a scheme of about how I see the complexity of vascularization and how I see the way that the young people must learn about this kind of procedure. But for ischemia, we have, besides the bypasses, we have the thrombectomy, and then it's important to because it's new, it's a different concept. And then I want to talk in another session about that. And we start talking now. Going to let me. Okay, we're going to talk about. It's very important to talk about how we're going to talk about the revascularization. There's a way to talk about the flow of the bypass. Okay, if you talk about the flow, the people talk about the high flow, medium flow, or high flow. But the problem is now with the use of flow meter from Charbel, you can see that sometimes the STA MCA, that is known as the low flow bypass, you can have a high flow with STA-MCA. And then it's questionable about the nature of that kind of classification. I rather prefer to use the first to third generation because for me, for educational purpose as well, is very good. And then now only to show you that I had the opportunity to talk about the same title in a book of my friend Pablo Rubino. He's a very good neurosurgeon from Argentina. And in this picture, we are with my mentor, Professor Evandro, and one of the neurosurgeons who I admire most, that is Rokuya Tanikawa. And my friend Pablo in 2016 in a congress in Argentina. And then in that book, I talk the same topic that today, the bypass from first, second, and third generation. It's very important when we talk about aneurysms that you must be master of clipping first. 90% of the cases of aneurysms you can resolve with clipping, and 10%, maybe 8 to 10%, in depend of the location, you need bypass. And MCA is most, but the rest of the aneurysms you need a bypass. Even if you are an expert in clipping, you need the bypass. For me, a vascular surgeon is not a vascular surgeon if he cannot do a routine bypass surgery. Revascularization is very, very important in this kind of pathology. The same for tumors. You need to be a master in taking out, for example, skull-based tumors, but you need, in some cases, less percent, of course, less percentage, 2% to 5% of the cases you can need a bypass, because the most important thing, and in the same concept is for aneurysms, the perforators are the important thing, the most important that you need to preserve. And the perforators, you don't have enough time, because the compromise in perforators is more or less 5 minutes of ischemia. And then there's no surgeon in this world that can do all the bypasses in 5 minutes. Maybe Shubin can do a STA M4 in 5 minutes or 6 minutes, but you need to revascularize more territory for this kind of lesions. Maybe you need to go to the carotid artery, you need to go to posterior cerebral or other type of arteries. I want to start always say thank you to my mentor, Professor Evandro, who passed away recently. And the other thing very important is to know about microsurgery and neuroanatomy. That I was very, very, very lucky, and I learned this in Brazil. And for me, these are the most important indication of revascularization. Okay, let me move this here. Okay, and then you see. The frequent indications, I have more than 160 now. I now have more, maybe 170 bypasses. And in paraclinal, for example, only 8% of the cases you need bypass. Most of the cases you can clip, and I said to you, you must be a master in clipping. And then, for example, frequent indications are fusiform on dissecting aneurysm without possibility of parental vessels vascular reconstruction. Which can talk about endovascular or exovascular neurosurgery. I always talk about exovascular neurosurgery, the microsurgery that we do, because we are not taking out the brain or whatever. You need to go outside the arteries, but preserving everything. In some aneurysms, you need a prophylactic bypass. What's the concept of prophylactic bypass? Prophylactic bypass, for example, if you need to make temporary clipping more than 5 minutes, more than 10 or 15 minutes, and the patient, for example, have no good collateral circulation, that we talked about this the other day, and it's more important. It's most important. It's more important in the ischemia that we will talk in the recent future. The prophylactic bypass. If you think you need to have a temporary clipping too long, you need to protect the brain with a bypass. That bypass is not forever, but sometimes, and we show you a case. For example, you think that you can preserve the internal carotid artery, but the internal carotid artery is occluded in the postoperative period, and the prophylactic bypass becomes a definitive bypass. And then it's very important that the bypass, when the patient needs collateral circulation, the bypass is going to work. Okay. The only misindication of bypass is when the patient don't need it. Is, I think, maybe in between 5 to 10% of the cases, but you never know. Okay. And then it's very important to know that this tool you need to dominate. And then the other indications of vascularization, when the patient failed the balloon test occlusion, is very important. If the patient failed the balloon test occlusion for cavernous aneurysm, you cannot use a flow diverter or whatever, you need to do a bypass. The revascularization, when the branches are included into the aneurysm wall, the typical case are the MCA dysplastic aneurysms. It's very important. Tumors. For me, the tumors are less and less frequent indication. Why? Because for me now, the skull-based tumor surgery is preserve the arteries and preserve the perforators. If you compromise the perforators, there's no bypass that's going to save you. You need to preserve. You need to be a master in this. And then what I talked to you is Moyamoya disease. Moyamoya disease is a very good indication for first generation bypass. And the other thing is the arterial occlusion. Acute or a stroke and chronic ischemia. I will show you a couple of cases, even we are talking about the aneurysm. And then here, the most important concept, you need to be patient for the young people. You need to be patient. You need to use the laboratory. This is the laboratory in my hospital on the 5th floor. Okay, small laboratory. We use rats, and we have and now we have more microscopes, 3 microscopes, and my fellows practice there. And then I want to say to you that I finished my fellow in 1999, and I did my first bypass, my personal first bypass in May 2005. I spent 6 years in the laboratory practicing, because here it's impossible without practice to do a bypass, because the bypass is the only surgery that you cannot make any mistake. If you don't do a perfect anastomosis, that bypass is going to occlude. Okay, even if you do a perfect indication or anastomosis, you have 5 to 10% that's going to occlude because the patient don't need it. But if you don't do perfect suture, the bypass is going to occlude for sure. Even if you use anticoagulation or anti-aggregation or whatever you want to use, if the suture is not perfect, you're in trouble. In my hospital, the first bypass was did in 1994. I started my residency in neurosurgery in 1995. Unfortunately, I didn't see this case, but the next bypass was done in 2005. The bypass that I did a second generation with radial artery, and 11 years after my professor, Dr. Loaiza. And when I was in Brazil, I was very interested in the bypass. And in Dr. Evandro, what I learned with him was only second generation bypass, or known as high flow bypass. And he did the high flow bypass with saphenous vein. But when I was there and I saw the results of his series, I see that the problem of the saphenous vein, the anticoagulation, the difference between the saphenous vein and the MCA. In that time, Dr. Shekhar started to use a lot in the radial artery. Then when I started my personal experience in Chile, I started using radial artery from the beginning, okay? Artery with artery. And it's very important that you need to learn of your masters, but you must not be afraid to change the things that you can improve. It's bad to be a copy of somebody. You always need to make some improvement, because this is our legacy. If you only copy other people, you have nothing to leave to the others. Okay, and then you need to try to improve and put your thing in whatever you do in neurosurgery. And I was very lucky in 2009. I was in the World Federation Congress in Boston, United States, and I was invited with this very good neurosurgeons. I don't know why they invite me. Till today, I don't know why. I was there with Shekhar, Edgar Natal, who is a very, very good vascular neurosurgeon and have a huge experience in revascularization from Mexico, Jack Morcos, and Fadi Charbel, who is very good in ischemia, I think the best in posterior fossa ischemia, and he developed the Charbel probe that you can measure the flow with the probe. And the other thing very important for me was knowing the Japanese people. Here in this picture is with Michael Lawton, Professor Kamiyama, Francisco González Llanos, a very good friend from Spain, very good vascular surgeon and bypass surgeon, and Rokuya Tanikawa, who, in my opinion, is the best neurosurgeon that I ever seen operating, skull-based and vascular neurosurgery. And here with Chubin and Fadi, we were in Italy in 2018, and I learned a lot of them both about ischemia. Ischemia is, for me, is the future of vascular neurosurgery. And then when we talk about cerebral revascularization, the concepts are very clear. We need flow augmentation or flow replacement. Flow augmentation is typical when you have ischemia, okay? Because flow augmentation is the way to do collateral. And the only way to create collateral is microsurgery, revascularization. And flow replacement when you occlude some artery and you need to replace flow at the moment. And you need for that, you can do for bypass or you can do opening the artery, for example, thrombectomy, endovascular or microsurgical thrombectomy. And this history started in 1967 with the first bypass STA-MCA for intracranial occlusive arteriopathy that was abandoned a lot of years about this diagnosis. Now we are operating more and more ischemia because the study now is very good with the test that we have today, mainly the new angiotomography, perfusion tomography. We have that that computer tomography with that kind of test. You can see the core of the infarction, the penumbra, and everything. And you can use as well MRI, but now the tomography, the evolution of CT scan is huge. We must remember that CT scan started in 1971, 50 years ago. And now the CT is the most important test that we use for ischemia. And then now the bypass, the STMCA, I use the name of first generation bypass. First generation bypass because it's very interesting to say that the first bypass that the young people must dominate is the first generation, STMCA and the occipital pica. STA-MCA for all the anterior circulation ischemia or whatever you need. I will show you some cases. And the second is in posterior fossa, occipital pica. You can use for ischemia, for aneurysms, a lot of diagnosis. This is a review that we published in 2010 with my friend Everval Figueiredo from Brazil about the aspects of high flow extracranial intracranial bypass. Now I use the name of second generation. Second generation because that is the second kind of bypass you need to dominate. It's different from the STMCA or occipital pica because that ones are alive bypass. Alive because the artery is alive and you only need to do one suture in the distal suture, intercranial suture. Okay, the high flow or second generation is a not alive bypass because you put a graft and the graft is not alive, and you need two sutures in the cranial side and in the cervical side or in the petrous carotid artery, whatever artery you're going to use. But you need two sutures. It's more difficult to do, take more time, and it is used for mainly for high flow. But I said to you that sometimes the flow, if you measure, you can obtain a high flow with a first generation. Okay, this is my experience, more or less. As Iype said, the most experience that all the surgeons have is third generation. Most of my bypasses are STMCA. The second generation is 30 only because now I will show you with the use of flow diversion in the intracavernous carotid artery, the indication of second generation of high flow going down. Why? Because as well, the first generation is very good for ischemia, and then the indication in ischemia is going more and more. You see in the right side of the slide, flow augmentation, first generation, flow replacement, second or third generation. What is third generation? Third generation is very difficult to do. It's an intracranial anastomosis. I will show you the cases, why you use this. I think I put in red, why? Because I think the vascular surgeon definition is when you can do a first generation perfect and you can do a second generation. Third generation is for experts. Is needed sometimes, mainly for difficult cases. I will show you, but you need to treat 95 to 99% of the patients you have with the first plus second generation. And then some aspect that Iype talked, the preparability study. You need to do an angio-CT, perfusion CT, MRI angiography, or cerebral angiography for catheterism. You can do whatever you want, but you need to have a very good study about the perfusion. That's very important. Some indications maybe for ischemia, if you don't have a problem in the perfusion, if you do a direct bypass, the bypass is going to fail because if the brain is not under ischemic conditions, the bypass is not needed. The other way to indicate bypass is, for me, less than 40 years old, my indication is universal. Why? Because I have cases in occlusions of carotid artery that the patients develop de novo aneurysms and ACOM, for example. Or the patient have late ischemia, and the publication said this is in between 5 to 15% of the cases, even when the VTO is tolerated. And plus 60-year-old is selected, okay? You base in your VTO, your balloon test occlusion, okay? Because the patient, most of the time, don't have enough years in the follow-up to develop the aneurysm, okay? The anesthesia is much better, the intravenous anesthesia. The systemic heparinization, I only use half dose, regular dose. I use only 2,500 units of heparin, and I use aspirin. In all the cases of ischemia, is permanent, but in the case of aneurysms, I put 24 hours before surgery. If I have a high risk of rupture aneurysms, I just put the aspirin intraoperative after I occlude the aneurysm, okay? And then we put the aspirin, and the first 24 hours, I keep the heparin until the aspirin start to do the job. I use always ICG, video angiography, Doppler, and sometimes I use flow meter as well. The probe to see when I have any doubts. And the post-operative study is very important. I use in most of the cases, angio-CT and perfusion CT. Sometimes I use MRI, and the angiography I only use when I have doubts about what happened with the patient, because for me, angiography had morbidity, and I don't want to have morbidity in a patient already treated, okay? And then, for example, if you do a trapping of the aneurysms and you put a bypass, you don't need to do an angiography because you exclude completely the lesion. Then the technology is very important. This is Pavel, the Charvel, sorry, micro flow probe. And the good about this is you can measure and you can make an index. It's very important, the index. If you have less of 50% of the flow after the suture, the bypass is going to occlude. In cases when it's hard, it's small,
Jorge,
or whatever, going to use the technology. Yes.
Jorge, two things. Number one, I mean, very good, excellent lecture that you are delivering. But we have, we have just 1 hour. So because I mean, this is one thing that I wanted to tell you, because all the feedbacks that we get, probably we are going at too long. So we will have multiple sessions. How many hour sessions that you want? Even if it is 5 or 6 sessions that you want, we can have 6 sessions, but people say
okay,
maybe more than 1 hour.
We can make like Mi Plata. We can do revascularization 1 today in 1 hour. If we stop when the time is up, and we can continue in the next session with the rest, because I have a lot of videos and cases to illustrate the concepts.
Yeah, so maybe we can do it for 3 or even 5 sessions, no problem. But we can strictly stick to 1 hour. I mean, so we have done half an hour, so we have 1 hour, half an hour more. And then one more thing is, since you're talking about Charbel's microflow probes, how would you compare that with the Flow 800 software, with the present one on the Kinebo?
What? Sorry?
The Flow 800 software, which the present one.
I don't have it, but one of my fellows have it, and he used it. But I think that that kind of analysis is when you think you're going to fail, or when you need to prove it for studies or something about the ischemia or whatever. But in my case, I think I consume more of my thinking in the indication. You know what I mean?
Right.
And when I make the indication of the bypass, for me, the surgery needs to be perfect. And then if I make the measures, it's very good. Jack Marcos, for example, measure everything. Charbel measure everything. But for example, most of the people who do bypasses have not these strict measures. because the most important thing when you're going to replace flow is that works. You see, for example, for me, is if the outflow of the aneurysm is 55 or 60, and my 2 bypasses that I did take over of 55 or 50 or 80 after the surgery, for me make no difference. You know what I mean? It's important only to avoid the infarction. And then I learned from Rokuya, for example, when I have doubts about my suture or the technique of my suture, I know for sure that when I have more than 80% of the flow, the operative flow that the patient in my bypass is going to work. If I have less than 80%, I'm going to fail, and the patient is going to have an infarction. You see, that is very important. But for me, the first 50 cases, I think, I put it another way. When you have less than 50 cases of revascularization, you need to use a flow meter. You know what I mean? Because the suture is you need experience to do a perfect suture, and you need experience to take less time. And then if you're going to take 50 or 55 minutes in a suture, and you have less than 50 cases of bypass, you need to use everything, because you need to know in the operating room that if the patient is going to fail. When I did my first cases, I did all the cases with flow meters, all the cases. And at the beginning, some cases, I guess, for example, I had less than 50%, and that bypass occluded. But in the experience, in some point, you always have a very good suture, and you know when you are failing. You know what I mean? And then I advise that because I don't want to say to the young people, if you don't have a flow meter, you cannot operate. No, you can operate. Okay, with the flow meter, is more sure the result, but you always are you be sure about if you are going to fail as well. Okay, and then for me, this, for example, the flow 800 is very good. The flow 800 is very good because you can have a study pre and post suture. But if you don't have flow 800, you can operate as well. For example, for me, for a revascularization, you must have IC green. It's very important, the IC green. And the other thing that you need is Doppler. You need that, and you need a CT angio and CT perfusion for preoperative and postoperative. The rest of the things, the flow 800 is advisable to have it. The flow meter, advisable to have it, but you can do surgery without that. Okay. Can I continue? Yes.
Yes, please. Excellent,
Okay.
excellent. So
Okay.
please continue.
And then I think today we're going to talk about first generation bypasses. Okay, because not to complicate too much the things. And then I'm going to show you the first case is an ischemia, because it's very important, because it's the present and the future. And with one case, we can learn a lot. This case is a patient from Easter Island, 4,000 kilometers isolated from everywhere in Chile, Easter Island, okay? And this patient have an occlusion of the left MCA. This patient wait for 7 days to be moved from Easter Island to Santiago, to the capital in Chile, because we don't have flights every day. It's hard to the move of a patient so isolated. It's very interesting, this case, because it's isolated. And this patient came with this watershed infarction, occlusion of the left MCA. You can see here, very interesting, the poor irrigation of the left MCA, very poor, occlusion of the carotid bifurcation. Then, when you have occlusion of the carotid bifurcation, no Willis circle present, impossible. And then this patient is for sure, the perfusion is for collaterals, leptomeningeal irrigation, because it's impossible, because you have an occlusion in the carotid terminus, and then only collateral for leptomeningeal. It's very important. And then in the perfusion CT, you can see the very poor perfusion of the left hemisphere. Very interesting. You need to do all in this patient. And then the patient came to an angiography in my hospital, and then the neurologist see the occlusion of the MCA, the patient pure perfusion, the patient have dysphagia when the pressure goes down, and hemiparesis of the right side. But the neurologist, they discharge the patient because they say you have nothing to do. And that thing we need to fight. We need to work with the neurologist to show them that the microsurgery is an alternative in the ischemia. It's very important because they don't know. And we don't work together with the neurologist. It's very important. And this patient got a very leptomeningeal irrigation. You can see here the irrigation of the left temporal lobe for the posterior circulation, not the PCOM, the temporal arteries, and the very good STA. And here, this is a mini pterional approach. For me, it's very important to show that you don't need a big opening in these cases. Mini pterional is good enough. And then this is the opening of the dura. For me, the dura, you can open in any fashion that you want. And after that, the Sylvian fissure. And you can see here the atherosclerotic change in the MCA, terrible. The bifurcation of the carotid artery, and it's very important for the young people. The atherosclerotic closure of an artery in intracranial artery is very hard to open. With the stenting, very poor results. The microsurgery is impossible. And the arterectomy in an intracranial artery is impossible. You need to pick better a STA MCA bypass. And then you can see here the very pure irrigation of the MCA. The arteries are white. You see a clot inside the MCA because this patient had an occlusion. And then you have the good opening of the Sylvian fissure. After that, we do the typical IC green. And IC green, you can see the artery that you're going to pick for the anastomosis. Okay, and then this is the carotid artery. The branch, you can see the fields first, and this branch feel retrograde. And then this is the best branch to do the anastomosis, because if you put a clip, temporary clipping in this artery, this is the end of the MCA. And then you can do ischemia in all the time that you need, because that artery is going nowhere. It's the finish of the artery. Okay. And then I put the two branches of the STA. And after that, I do this rubber band from Japan, the fish mouth opening in order to increase 4 times the surface of the anastomosis. It's very important. If you don't use the fish mouth, the size of anastomosis 4 times less than using the fish mouth. And after that, I did the bypass in the artery that I took. I'm going to skip this because it's not important. We use heparin, of course, in the artery. After that, you use the blue dye in order to put better contrast for doing the suture. And after that, the most simple, the most effective, the anastomosis that all the vascular stages must dominate the terminolateral STA MCA bypass, M3. For ischemia moya, we use more M4, but M3 is a good artery to do the bypass. And this is, I prefer to use separated stitches. A lot of people like the continuous one because it's faster. But for me, as I told you, the time is not the most important issue. For me, the most important issue is doing a perfect anastomosis. That's why I study a lot the patient preoperative. And in this case, for example, I use the IC green to pick up the better artery to do the bypass. Okay. And then we did the suture. I released the clips, and I want to show you the very beautiful change in the irrigation of the brain. And we can see here now. This is the IC green again. Here, Okay, and you can see the first change. The STA feel the artery first. Remember that artery feel much delay in compared with the other branch of the STA. And now the MCA, sorry. And now first branch that feel is the one we did the anastomosis, and the other one is now is the slow one. And that is the first sign that the anastomosis succeed. Okay, and after that I will show you the second sign of the anastomosis is a success. Is this? I have the CT scan of the patient, and you see here the STA, and look at the MCA. The MCA is still very poor, very poor. This is in March. The perfusion improved immediately. It's very important that the perfusion is immediately the improvement. But the angio-CT is very important when you follow the patient, because in this case, 3 months after this, we did another angio-CT, and you see the change here. What's the change? The change is the growth of the STA, and not only that, you need a growth of the MCA almost normal. Look at this. Very poor, normal. 3 months, very poor, normal. That's the sign that the indication in this patient was perfect, because the patient needed. This patient only aspirin 100 millimeters per day, atorvastatin, of course, and all the things for the hypertension, and not quit smoke, control of hypertension, everything. But you see here, ischemia is very important. We organized in Chile in 2019 a symposium of ischemia, because for me, ischemia is the future. All my colleagues that we talk about, and I was with them, came to Chile. The next time, Iype must come, because we will start to work and do workshops and everything to show this the revascularization. In 2020, I had the honor to be invited to Zurich, to the 50+3 years of anniversary of the first revascularization for Professor Jason. And then to complete now the 20 minutes that we have left, the first generation bypass. The first generation bypass is the tool for 90% of the cases. For example, this MCA with branches coming from the sac. What we did in this case, we preserve one branch, the biggest one, and do a STA MCA to the frontal branch. You can see here the frontal branch coming out from the aneurysm, and now this is the STA, one of the branches. The other branch I preserve, and the revascularization. The typical case, this is the scheme of the surgery, the most simple indication. Why? Because when you clip, it's easy sometimes to preserve the main trunk, but the problem is the tiny branches. And in this case, for example, that I show you, the tiny one was the frontal. In the frontal is very, very important, because in dominant hemisphere is going to Broca, and then you need to preserve, and sometimes it's impossible to clip. The other very good indication, and for cure for the cases, is the serpentine dissecting MCA aneurysms. Most of these cases are giant. Most of the cases are thrombose. In this case, it's very, very interesting that the patient have a proximal stenosis in the giant aneurysms. And then in this case, only with the STA-MCA, you put an inversion of the flow, and the aneurysm completely thrombosed, and the patient is cured only with one STA-MCA anastomosis. And I will show you the case here, because I show you this case because look at it, this case is from 2005, very old case, very old case. And then it's very interesting because the concepts it take 15, 20 years are still up to date. And then look at this, a huge approach. This is the terional. Now we use only mini terional. The bone flap is this size. The skin is much small, the opening. And then the dissection of the STA is very good exercise for the young people. For me, it's very important to say to them that, or to you listening, that you need to use the microscope. It's very important. That it's a very good exercise. because you take out the adventitia. You can see here that the branches came out from the sac, impossible to clip. And what I did in this case, very old case, I only use a triangular opening of the STA, no fish mouth. And then in this case, the suture was very small, and it's good for me because I only take 22 minutes in the suture, but the surface on the opening is small. I prefer today that I'm very faster because I have more experience to use the fish mouth always because it's safer. Okay. And then this is the anastomosis, only one anastomosis. And the patient in the postoperative, this is MRI because in the first cases I always did MRI because I want to prove that the patient have not infarction. Now I have nothing to prove. And then sometimes I do MRI, sometimes I do angio-CT because the most important is the clinical status of the patient. Okay. And then this is the STMCA, this is the patient, this is the angiography. I said to you that today I rather prefer to use CT angio because it's not invasive. For example, so if you have a young patient that have an intracavernous aneurysm, you can do now a flow diversion. It's a very good alternative. But if the flow diverted doesn't work, you can use in a patient that tolerates the VTO and is young, for example, this patient 40 years old, I do an STA-MCA. Why? Because the patient tolerates the occlusion of the carotid today, but I don't know what happened in the future. I told you, I don't know what happened in 15 years, in 20 years. And what I do an STA-MCA is going to offer a flow, maybe low flow for the patient per generation, maybe high flow. But the good thing, the STA-MCA is alive. Remember always, alive bypass. The bypass can grow. I'll show you the ischemic case. Okay. In this case, I put an STA-MCA and the bypass work for this patient and prevent the patient to have an ACOM aneurysm, for example, 10 years after the occlusion. Okay. We have, for example, prophylactic bypass in complex aneurysms. Why? Because the patient tolerates VTO for occlusion of the carotid artery. Okay. But the problem are the perforators because I need to do trapping sometimes in order to clip. And then I put a bypass. For example, this is one of my most difficult cases that I ever operate. This is a huge paraclinal right aneurysm. And you can see in the case that we have a stenosis of the carotid, I put 13 clips, 13 fenestrated clips, was huge case. But we have A1 is okay. A carotid artery is okay. But what I have in this prophylactic bypass, because of my clipping, I have an stenosis of the carotid and the anterior cerebral artery, even they both are patent. But my STA-MCA bypass, this patient had 15 years since I operate, is still open. Why? Because always a bypass can come from prophylactic to definitive bypass. Because you never know how your clipping is going to end. And sometimes I will show you in some cases of second generation in the next session. For example, I did bypasses for replacement, second generation bypass, for example, and I can clip the aneurysm. And that bypass, for example, after a week occluded because the patient don't need it. And then the prophylactic bypass is very interesting concept, but the bypass you need to use in every case that you think that you're clipping or what you're going to do with the patient, keep an stenosis or even an occlusion of your artery. For example, look at this case. Terrible case. This is a young girl, 22 years old, with this huge aneurysm, with pan-hypopituitarism, and like a donut, you know, this sign show you that you have a problem with the wall of the carotid artery. And then maybe here, for me, my concern is the anterior choroidal, because I can tell that for me it's impossible to preserve this carotid artery because it's not possible to clip. You have calcification. In a young person, calcification is terrible for clipping in every person. But if you have a very young person with the calcification, terrible. You can even think this is a cardiopharyngioma or whatever. You know, that's important to use contrast, you know, the angiocity, because if you think that it's a cardiopharyngioma, you go for the nose, you had a very good surprise when you open the cella. Okay, it's very important. And then in this case, look at terrible case, no compression of A1 of the other side, and then what we did a trapping of the aneurysm, surgical decompression, and very important. Look at the space that we gained. The patient was almost blind. Now she's completely normal. Only she have a diabetes insipidus that she need the desmopressin and nothing else. All the rest of the thing is okay. And this patient, you can see the trapping, the calcified portion never disappeared, but the rest of the aneurysm disappeared. Look at this is a late study. And the other concept here that I will tell you in these sessions all the time, because repetition is the key of learning. Look at the right side STA, look at the left side STA. Look at this, 2 times normal. Why? Because the patient needed it. The main sign for you as a surgeon that the patient needs your STMCA is the maturation of the bypass. Very interesting concept. And then this other thing. Sorry?
Yeah.
Okay, I have 10 minutes. And then the other thing, we go, like Iype told you, the double STMCA. Because when you have an MCA aneurysms, the most common indication, and you have the 2 branches compromised, you see here an aneurysm in one branch, here an aneurysm in the other branch, you need double STA bypass. And then you can see here one of the branches, the second branch in an aneurysm in the bifurcation. This aneurysm is sutured because for me, put a clip was a problem for the revascularization. And then I just going to show you some very important concept of the IC green. I did the first bypass, IC green, okay. Now now we do the second bypass, and you can see here something very important, the filling of one bypass and the second bypass delay in the filling. This is a sign of poor technique suture. The only way you need to deal with this is you need to do the bypass again. You don't care about the time. You need to do a perfect bypass. And now 2 bypasses fill at the same time. Very good sign that everything is okay. After that, I made the trapping, complete exclusion of the aneurysm, and the double barrel bypass is working. 1 bypass, second bypass. Then it's very important you use your imagination. The other issue, very important, is can you do a bypass in a subarachnoid hemorrhage? Yes, but it's very hard. And the problem with the bypass develop vasospasm, the same that happened with the regular arteries of the brain, because this is a live bypass. If you use radial artery, no vasospasm in the bypass, because the radial is a graft, and then have no problem with the vasospasm like the STMCA. This is a rupture dissecting M1, M2 aneurysm. What I did in this case, I did a STA-MCA and trapping. And you can see the follow-up, the same thing, the modulation of the bypass or growing of the bypass. STA and the MCA, you can see the follow after 6 months. Look at the size of this artery, it's huge. But at the beginning, this artery developed vasospasm and then resolve after the 21 days. Next level of bypass, even is a first generation bypass, for example, is the STA-PCA or the STA-SCA bypass, okay? Because you need to go very depth. In this case, this patient, very young patient, 51-year-old, got a third nerve of the left side, and you can see here the thrombosed, partially thrombosed STA-PCA aneurysm. And what we did a subtemporal approach, and then you can see here the fourth nerve, the tentorium, the SCA, the PCA, and what we did a terminal anastomosis between the distal portion of the PCA to the STA. It's very hard to do this bypass, but you need to do it sometimes and it's very good. Normally, the relation between the STA and the PCA. Okay, and after that, you can do your trapping. This is the MRI, and this is late follow-up, and this you can see here the bypass. This is a 3D angio that you can see the bypass, the trapping of the aneurysm. Here you can see the bypass again for the floor of the middle fossa. And the most important thing, the aneurysm disappear in the follow-up. And you can see here the patient completely recovered of the third nerve. And this is the closure. Now I open the, it's very important to say to you that the ischemia of the flap is very important in these cases. I'd rather prefer now a flap in two pieces, not the trauma flap. The trauma flap, when you take out the STA for bypass, it's very hard to close the skin because of the ischemia of the flap. It's a concern. Rocuya, for example, have 40% of the ischemia of the flap. The other type of the first generation bypass in this I'm going to finish because I have only 5 minutes, is the occipital pica. The occipital pica, the problem is the harvesting of the occipital artery. That's the only concern, but it's very good. For example, these are 2 cases of, in the right side, of course, we can use now a flow diversion of a stent, but sometimes the patient can decide to go to the bypass. And in the left side case, this is a dissecting rupture, dissecting a pica aneurysm is impossible to another technique. In this case, we do occipital pica and trapping of the aneurysm. This is the first case, and only to show you that we made the trapping of the vertebral. That's completely pathological, dissecting aneurysm. Now I'm doing the trapping, and I preserve here is the MRI, and I preserve the pica with the here you can see the occipital pica bypass. Very interesting case. And then the second case is this is a dissecting rupture in a unique vertebral artery in the practice, because the other vertebral is very hypoplastic, and we did the occipital pica bypass. I show you all cases. I have a lot of cases new, but this I show you all because the revascularization is here for a lot of years. We must not quit the revascularization. We need to use more and more every day because of the ischemia. We must not quit for the young people. And this is the revascularization of the pica. And after that, the trapping of the aneurysm. I open the aneurysm, and you can see here the preservation of the vertebral, the occipital pica feeling very well. And the most important thing, the same. This is the difference between the trapping in the dissecting pica. This is the trapping in a vertebral one. And the most important, always you need to do a postoperative angio-CT or angiography, because you need to prove that your bypass is patent. Okay, and sometimes, for example, it's very important because in these 2 minutes that left, sometimes in some neurosurgeons say to me, you need only to do very well planning bypass surgery. But sometimes you think that you can clip, and in intraoperative, you need to sacrifice the artery because it's not possible to clip and preserve the pica. For example, this giant thrombosed aneurysm. This is the look at the aneurysm, the pica coming. I think it's clippable, but when I went to the surgery, you see, everybody said to me, no, this is a straight clip, no problem. It was impossible to clip. I occlude the pica all the time. And then what I did the best thing. I did occipital pica bypass, and after that I clipped the aneurysm in the same fashion. But I don't care about the pica because I revascularize the pica, you see? And we solve the problem of the patient. We preserve the vertebral very nice, and we preserve the pica with the bypass. And then you must not quit revascularization. Okay, I'm going to stop now because we have just 1 hour. And in the next session, we will talk about the second generation, third generation, and maybe we will see, because I have combined revascularization that is very interesting as well.
Okay, excellent talk, Jorge, as usual. Excellent talk. We had a question which we answered, but the next session, I would like you to start from harvesting ST. How do you harvest ST? For example, many people mark the ST and then harvest it. My good friend Binzu, he does an in-flap harvesting, which means he makes a flap and then makes the harvesting. This is very much faster for ST. So anyway, you are dividing the ST at this level, and then you need only that much. You need only that much, and that much ST to do M4 anastomosis, and it saves so much of time. So in flap anastomosis saves very much a lot of time. So rather than harvesting the ST. In fact, that doesn't matter in some people's opinion, because that is not occlusion time. That's not ischemia time. So how much of a time you want to take, you can take. In my Japanese friends, Takizawa, they say it doesn't matter how much time you take for harvesting instead.
Like I said to you before, the most important is because I learned this for experience. In the beginning of my series, I always said to the anesthesiologist to say, how much time, 5 minutes, 10 minutes, 15 minutes, and what happened with you? You put nervous, because when you have 10 minutes and you have 15 minutes, you start to think, okay, this thing, look at this. In the bypass of STA, PCA that I show you, I take 90 minutes, 1.5 hours, and the patient did well. And the patient, because most of the surgeons said, okay, if you take 9 minutes, and the patient have no infarction, it's because the patient don't need the bypass. They said to me. And then I said, my response is, if the patient don't need the bypass occluded. And don't tell me about 90 minutes in the future, because the occlusion of an NCA today is 24 hours, the time that you have for thrombectomy. And then please don't talk to me about time. Talk to me about do the perfect bypass. If for you the perfect bypass is continuous suture, do continue. If for you is separate the stitches, do separate it. But please do perfect bypass. Please do fish mouth always, because for me, the biggest, the better, because if you have a very tiny suture, for example, the case of Moya Moya. Moya Moya is the simplest bypass, because you go for M4 and you take the STA from the. I don't do the flap as well. We open just over the STA. I go inside. You see, but in these cases of aneurysms or tumor, you need to expose the pathology, and then the concept is different. In the ischemia, Moya Moya, chronic ischemia, stroke, the problem is ischemia, and you need only to know about ischemia, okay? But when you have aneurysm of tumors, the problem are the pathology. And you need, I will show you 2 cases that I have terrible cases. 6 centimeter aneurysm. In 6 centimeter aneurysm, you need to be a skull-based surgeon, you need to be a vascular surgeon, you need to be a preacher, you need to be a, a lot of things, because you need to be very patient, almost something spiritual to do this kind of surgery. Because, for example, I always told to my fellows, you are operating for 20 hours. And the problem is, in the 20 hours and 1 minute, you need to be sharp and clear. Because in that moment, if you made a mistake, the patient will have a problem. And then this is the good thing about the bypass surgery. The good thing about bypass surgery is very hard to do, but force you to be perfect. Because if you're not perfect, you have occlusion. There's no other answer. There's no margin, If you made a mistake, you're done. It's very hard to fix. Of course, you can fix, and we will talk with Iype how you can fix, for example, the transfixion when you take the back wall with a stitch. When you have how you avoid that. The tricks are very clear for that. But the most important trick that you need to have is patience, and the second thing is laboratory. Nobody was born knowing how to do a bypass. This is practice. Some people think that they are illuminated, illuminated for something, and they will come I knew cases, Iype, from surgeons with no experience, no laboratory, no nothing. They have a patient aneurysm and they try to do a bypass. Of course, it's going to fail. I take 6 years. When I put my first bypass, I have operated 400 aneurysms. After 400 cases was my first case that I said, okay, I'm prepared. I will try. You see, it's very important to be patient, be humble for the bypass.
Yes, absolutely. Jorge, so excellent talk as always. Two things. Next session, I hope Eugenio will be watching and John will be watching. So next session, we'll go ahead and we will talk about starting with positioning, craniotomies for occipital artery harvesting, craniotomies for ST harvesting, and then how do you do the bypass to MC. So this is what we will deal with in the next session, and with cases, with all the steps. Also, we are having this session in March. March, we are having a meeting in Los Angeles. So the skull base part, I'm chairing it. And we have the WFNS Anatomy Committee coming with us. So if you would like to come and demonstrate your Mi Plata in Los Angeles, you're welcome. The WFNS Anatomy Committee, Vlad Benesh, Imad, Ramesh, Salman, Pablo, all of us are coming there. We'll have a skull base workshop there. We'll be glad to have you. And also after that, we go to Bogota for the World Congress. And then we have Galapagos in between. That will be a pleasure trip. And after that, we go to Rio, Louis meeting, where I will again chair a session on innovations in neurosurgery. So, so these innovations will have 10 papers from young neurosurgeons, and there is a prize for $1,000. So maybe you should tell your residents to come and present something about your innovations as well. So this is what the plan is. If you are joining up, we will be honored to have you with us. And for the Los Angeles meeting, we have a lot of people who are very good at AI, computers, engineers. So we have this, it's a SBMT meeting. So we are looking at innovations. So I think exoscope is the future. Maybe not even exoscope, a hybrid between an exoscope and an endoscope with navigation. So all three in one screen rather than 3 different screens.
I name the future for me is the hybridoscope. You can use exoscope or microscope in the same equipment. You can shift.
Yes. Yeah, but one machine with both rather than having 2 machines. So we are looking forward to that, and even that is navigated so that you don't need to use navigation also as a separate screen. So we are looking to work towards this. So this is what we will be presenting and looking at. So I would want your participation, and I'm looking forward towards the next session. So we have exceeded time by 8 minutes, and that is primarily because of me. I'm sorry, but excellent session as usual. Excellent session, beautiful session. So we will go ahead and do the techniques we'd use next session. So you decide the date and we will publicize it.
Thank you.
Okay, Stephanie, close it up.
Yes.
Thank you, Doctor. Thank you for all your thoughts and all your acknowledgement that you gave us. Thank you also, Dr. Iype, Cherian, for making this possible. And it sounds very interesting what you have planned for next year. And we hope you have a great time. See you next session. And thank you to our attendees for coming. And we will be waiting for you in the next session.
See you.
Very good.
Thank you, guys.
Thank you, everybody.
Thank you, Jorge.
Okay, very good. Okay, very good. Stephanie did great.
Thank you,
There
doctor.
wasn't much to do, right?
Yeah, but it was very interesting.
Yeah, Francisco, we started because you weren't here.
Good
So,
afternoon, doctor.
the next one you can have. We have a couple. We have Victor's tomorrow, which you've done the Kahoot, right?
Yes, I'm making the Kahoot, and I hope that for tomorrow we will be ready.
Okay, good, very good. Okay, how you doing, Dr. Hareen? Jorge Hareen? Did you have a question or something? I didn't know if you did. Jorge, you're muted. You gotta unmute. Yeah, unmute there. Maybe, I don't know if it's possible. Well, maybe you don't want to. Okay. Okay, yeah, tomorrow we have Victor, and Sunday we have two. We have Griselda's Women in Neurosurgery, and Stephanie's going to be there, I hope. And we also have a talk on strokes at 6 o'clock by Rolando. Let me show you Rolando's. Let me show you Rolando's write up. Okay, there it is. Okay, I'm going to share the screen here. Okay, Rolando, I think you guys know him, right? Rolando Cardenas. He's a neurocirujano de Argentina. En televisión ha tenido una entrevista sobre his app en Buenos Aires. Es un programa de televisión donde hay entrevista. Él ha hecho esta aplicación para bajar tiempo, para reportar un stroke con su smartphone. Entonces él va a explicar. Entonces, okay. Okay, mucho gusto a todo Vanel. Thanks everybody for coming.
Thank
And
you.
Tal vez Ahanga. Ahanga, how are you doing? You guys got to meet Ahanga. He's from Uganda, Congo, I think. Ihanga, you're from Congo, right? Maybe he stepped away. Yeah, Ahanga's a neurosurgeon from not Uganda, I think Congo. But Ihanga, are you there?
Yes, I'm here. It's Congo.
Oh, the Congo. Yeah, I'd like you to meet a couple of students from Peru. One from Bolivia, one from Peru. I don't think they've ever met a neurosurgeon from Africa.
Yeah,
This is a big day for Stephanie. Look at this. It's like your birthday.
Yes,
Thank you.
it's a big
Full of
day. Yeah,
surprises.
and
Good
it
night,
was a
Doctor.
good webinar. Yeah, fine. I'm fine, and happy to meet you here. And yeah, it's good. And with Dr. Bennett, I think we shall have to meet a couple of times.
Yeah, they're helping. They're helping announce and moderate. And Francisco's doing a little bit of program work with Kahoot. It's a platform that gives a quiz online, and it lets people vote that are just watching on they can vote on their smartphone for various questions, survey or poll questions, or just medically related questions. And it's quite good, right, Stephanie? It's quite good.
Yeah, it's very funny, and the winner gets a ticket to Miami to the headquarters.
Yeah, you can't sleep the whole time. You got to listen, right?
Yeah, it keeps you like, I have to hear, I have to answer right.
Okay. Okay, Ahanga, you're welcome to any webcast we have.
Yeah, thank you so much. I enjoyed this one of today, and I think next time I will be there.
Good, good. We welcome you. We're having a lot of talks. And you're my friend on Facebook, right?
Yes.
Yeah, so you get a lot of notices of conferences, right?
Yeah.
Yeah, so you know. So,
Yeah.
okay, everybody. Good night.
Thank
Thank
you,
you.
Doctor.
Yeah.
Good night.
Thank you.